Now as we move downward toward larger and larger thoracic vertebrae, then we'll end up at a point where now the head of the neck is setting entirely on the body of this vertebrae, and the tubercle is still connected here. So in the upper ones where we had a demifacet, this is actually a true facet where the head of the rib sits. So again, as we make the transition downward from thoracic to lumbar, and you could count them and there would be 12, or you can look for characteristics that are kind of unique. So again, as we look at these two vertebrae are structurally fairly similar, very broad, blunt spinous processes, and fairly large bodies. But you'll notice on this one we have a rib facet, this smooth surface right here, and it's absent on this one. So this is actually T12, the last thoracic vertebrae, and then this is L1, the first lumbar vertebrae. And so lumbar vertebrae do not interact with ribs. So we were just looking at lumbar vertebrae. So L5 is what would sit on the sacrum. So the two would interact like this, where we have the inferior articular surface of L5 interacting with the superior articular surface on S1, which would be the first sacral vertebrae. But what you'll notice with the sacrum is the bodies of the sacrum fuse. So we actually have 5 sacral vertebrae that fuse together, 1, 2, 3, 4, and 5. And then because the holes on the rest of the vertebral column are coming out the side, those intervertebral foramen, because these are fused, now the holes come out the anterior surface and also the posterior surface of the sacrum. And you can see that with the spinous processes. So from a clinical standpoint, if we had an occlusion here on the anterior surface, then we would want to clearly be able to state that to someone. So we call the openings from the anterior view the pelvic foramen, and then we call the openings from the posterior view the dorsal foramen. So we refer to it as 2 different openings so we can refer to the surface. Now, the way this works is all of your weight of your body is transferred from L5 to S1. So S1 has quite a lip on it. So this lip is called the sacral promontory. And then as we look at the edge of it on the side, there's a real smooth surface over here. And it's ear-shaped. And so since it's ear-shaped, it's called the auricular surface. And it's actually where your hip bone, your os cox, is going to set to help form the pelvis. And we'll look at that and how they interact together as we do the hip bone. Now, typically on human skeletal bones that we get to study, the coxial vertebrae, or the real small tail vertebrae, are oftentimes absent. But we would have had 1 to 3 bones, smaller bones down here, forming our tailbone. And you'll be able to see those on plastic models as you look in lab. So if we look at an articulated skeleton, then the bone that's anteriormost that connects the ribs anteriorly is called our sternum. And we can divide the sternum into 3 component parts. So notice there's a ridge right here, which is cartilage in younger people. And so the upper part is called the manubrium, which is this triangular part that the clavicle is attached to. And then this long part of it is called the gladiolus, or body. And then there's this tapering part at the bottom, which is retained as cartilage in a lot of people, and that's the xiphoid process. So remember, if you've had first aid training, the xiphoid process is one of our landmarks looking for CPR points. And so when we look at the sternum, and if we look, there's a notch that we can see at the top right here. And since you have some large veins that go down behind it, then it's called the jugular notch that's on the manubrium of the sternum. So if we look at a disarticulated sternum, then again, this upper part's the manubrium. The notch we're seeing here is the jugular notch. And then this piece is the gladiolus. Now, interestingly, this person has a hole in the bottom of their gladiolus, and I'm not sure if that was a gunshot wound or a knife wound that occurred. And then the xiphoid process would extend off of this. So what attaches to this are ribs. And so the interesting thing about ribs is that if you start with the first rib, then the first rib is really flattened in a plane that we can see here, so that the first rib is flattened on this plane. And you can see that it's very, very flat. And then the ribs tilt, so that now the flattened portion is lateral, whereas the flattened portion up here was superior or cephalic. So our rib changes. So when we look at a rib, and it's very pronounced on this first one, then this is what would connect to the body of the thoracic vertebrae. So that's the head. And then if you recall, if we have an enlarged area that's a head, then the narrowing below the head is a neck. And then we have this projection upward right here, which is a tubercle. So at one end of the rib, we have a head, neck, and tubercle. At the other end of the rib, we actually have a flattened area where hyaline cartilage attached, which is called the costal cartilage. And then that cartilage would attach this rib to the sternum anterior. Now if we go to a lower rib, as we just talked about, instead of being flat on this plane, now it's converted to as flat on this plane. But we still have a head, we still have a neck, and then posterior we can see the tubercle. And then the other thing about a rib that's unique is if you look at the internal surface of the rib, there's actually a groove on the internal surface of the rib that's called the costal groove. And so this is always inferior. So when you're looking at a rib, if you have it oriented like this where the groove is on top, then that would be on the wrong side, so you'd have to rotate it to the other side so that the groove is down. So you can tell the difference between a left and right rib if you just look for this costal groove on that. And then again, costal cartilages would connect to this. So if we go back to the articulated skeleton over here, then what we would see is all of this dark material is representing hyaline cartilage. And we would see how the ribs are attached to that. So that allows us to actually divide our ribs into groups. So one way we could do it is we could count down, and what we have is we have 7 true ribs and 5 false ribs. So if we could count down 1, 2, 3, 4, 5, 6, 7, then that would be our 7 true ribs. Notice in all of these, it's very easy to see that the rib, the hyaline cartilage, and the sternum are all connected to one another. And then on the 7th rib here, you'll see that same pattern where here's the hyaline cartilage going directly to the sternum. So what makes a false rib, and the best example are these 3 ribs right here, is that the cartilage of this rib attaches to the cartilage of the next rib above it, and the cartilage of this rib attaches to the cartilage of the rib above it, and then the cartilage of this rib attaches to the cartilage of the rib above it. So these all 3 essentially attach to the cartilage of the 7th or the last true rib. So that's why these are false ribs, because they have no direct attachment to the sternum. Now your last 2 ribs actually have no anterior attachment at all. So your last 2 false ribs are referred to as floating ribs because they have no costal cartilage associated with them. And notice that they taper too. And these bottom 2 ribs are largely designed to protect your kidney posteriorly.